Hello, this is Dr. Gay from First Look MRI, and this is a 17-year-old female who is the daughter of one of our technologists. And so just today, she was playing sports and got an apparent dislocation of her kneecap, and her knee was locked, and the tech said that she could not get the kneecap to go back to normal position. So they went to their urgent care clinic, and the wait was going to be very long, and so she decided to see what was going on. The kneecap was not lateral. Normally when kneecaps dislocate, they dislocate laterally and they pop right back into place. And again, she could not get it into place, and she said it wasn't lateral either, it was inferior. And so when you have an inferior patella, you worry about a rupture of the quadriceps tendon. So we decided to have her rush in and get an MRI to see why her kneecap was too low in position and why her knee was locked in 90 degrees of flexion. So on this sagittal view, we see the femur coming down, we see the kneecap in the front, we see the tibia down below, and we see the quadriceps muscle up here, quadriceps muscles, and the quadriceps tendon coming over. We see the same thing over here, and you can see that the quadriceps is nice and normal. Jet black, is not stretched or torn, there's no edema within it, normal in appearance. The kneecap is too low. Instead of being in front of the femur over here, it's hung down underneath the femur. So it's just subluxed below the femur, but it's not, there's no edema within the kneecap. The cartilage look normal. The patellar tendon that comes off the bottom of the kneecap to the tibia also looks completely normal, pristine. There's no injury. So kind of an unusual appearance to have a completely normal quadriceps tendon, strangely low position of the kneecap, patellar tendon fine. A little bit of fluid in the front of the knee joint, not much. And so now we're going to look at the ACL, which looks good right here. The PCL, posterior cruciate ligament, looks good here, so that's fantastic. When we went off to the medial side of the knee, we can see that the medial femoral condyle looks completely normal. You can see gray cartilage and the black cortical bone, and we see a little black wedge here, the meniscus in back, the meniscus in front. This is called the anterior horn, posterior horn, and the meniscus is perfect, normal in position. Over here we see the meniscus, over here the little black triangle, that looks totally normal on the this medial side. But the lateral side didn't look normal. There's fluid over here which is white. We should see a little black triangular wedge, but instead we see fluid. And on this view we see a darkness over here in the inner side. So this is the meniscus is flipped into the central knee joint here, or flipped inward. It goes across the weight-bearing portion of the knee and into the back of the intercondylar notch here. So an abnormal position of that meniscus. So we're going to go across on this view to see if we can see what that looks like. And on this view I put an arrow on a meniscus fragment. So this is the meniscus. It looks wavy. The anterior horn is right here. And then right behind the anterior horn, touching it, is the meniscus body. So the whole meniscus body and the whole posterior horn are flipped or dislocated inwards, and they cross right through the anterior part of the weight-bearing joint, and they go back over here into the intercondylar notch, the posterior margin of the intercondylar notch. So again, most of the meniscus is flipped inward, and that abnormal position of the meniscus is making the knee get hung in flexion like this. And so this piece of meniscus is blocking the knee from swinging back out to normal in position. It's locking it into the abnormal position. So we did the entire scan and decided, they better go see the orthopedic surgeon to get this in. This big displaced meniscus fragment here in the middle, or the meniscus that's flipped inwards, they're going to probably have to go and get the knee straight and then repair that meniscus. But after she got off the table, her knee was able to go straight. So we're like, wow, let's do some more images just to see what this looks like. And this is, again, locked in flexion. This is that meniscus here that's folded upon itself and displaced inwards. And now we're going to go to the post knee whenever she came out. So she came out, her knee went straight, and her kneecap looked like in normal position now. Beautiful up front. There's no subluxation. The cartilage looks great, so fantastic looking meniscus, no subluxation. And then we did a couple more views here and here. Now in these two views we see that the medial meniscus still looks normal, but the lateral meniscus, previously there was fluid over here and the meniscus was inside. Now the meniscus is flipped back to the normal position. Here it is out where it's supposed to be. If we go off on this view here, we see that the lateral meniscus, here's the anterior horn, body, posterior horn, completely back to normal position, and there's no abnormal signal in the meniscus. So it just flipped into the joint, and when the knee went straight, it flipped right back to normal position, and it looks pristine. I don't believe I've ever seen that before. Sometimes we'll scan patients and they have a meniscus in normal position. They've had trauma, so potentially they could have had a dislocated meniscus, and maybe it's flipped back and just looks stone cold normal. So they avoided the emergency room, and they're going to follow up with a physician in the future, but it's not going to be as emergent now since the meniscus is normal position. Her symptoms have gone away. She feels fine. And interestingly, there's no joint effusion. There's not even fluid in the joint, as one might expect with a significant injury like that. So, an unusual case of a dislocated meniscus that has flipped back to normal position. And again, when it was dislocated, it was resulting in locking of the knee like this. And again, flipped back to normal position afterwards. Thank you very much.